Nagarcoil.
The topic for today is malaria, dengue fever, leptospirosis in pregnancy. Swine flu has already been covered. All these diseases have a devastating impact on pregnancy, affecting the mother and the baby. First, diagnosis of malaria, clinical and parasitological. Clinical diagnosis, it is the days which counts. In low-risk settings, how many days before? And in high-risk settings, how many hours before? And here the presence of anemia plays a major role. And again, the pallor of the pelvis is the most reliable sign. And in malaria epidemics, all patients with history of fever are encountered. Parasitological diagnosis. The gold standard technology is thick blood smear technique. Presence of malarial pigment in the circulating phagocytic leukocytes is the pathognomonic sign of recent malaria when parasites cannot be found in the blood film. Serological test for detection of antibodies against asexual blood stage malarial parasites is very important. Of course, the PCR assays and placental blood smear, the negative test may not rule out malaria and positive test may not confirm malaria. So repeat 2 to 3 times at intervals of 6 to 12 hours. Effects of malaria on mother is of course only 3%. Megaloblastic anemia, hypoglycemia, metabolic acidosis, jaundice, renal failure, pulmonary edema and respiratory distress, cerebral malaria, DIC, hypothermia and increased maternal mortality rate. Effects of malaria on the fetus is rather more, 15%. Spontaneous abortion, missed abortion, preterm labor, fetal growth restriction, intrauterine fetal death, low birth weight babies, congenital infection, perinatal death and stillbirth. Management of malaria in pregnancy is categorized into 3 chapters like energetic, anticipatory and careful. Energetic management includes admit all cases of P. falciparum, assess severity of symptoms like pulse, BP, pallor, icterus, temperature, hemoglobin, parasitic count, SGPT, CBG, serum creatinine and serum bilirubin. Anticipatory management, you look for complications by regularly monitoring the maternal and fetal vital parameters. Careful management includes avoid drugs which are contraindicated in pregnancy, avoid over and underdosing of drugs, avoid fluid overload and dehydration, maintain adequate intake of calories, identify P. vivax and P. falciparum. Now treatment of Plasmodium vivax. Chloroquine is the drug of choice. 10 mg per kg body weight day 1, 10 mg again day 2 and 5 mg day 3. Chloroquine is 600 mg base. Normally 250 mg tablet has 150 mg base. So that way 4 stat first 0 hours and after 6 hours 2, after 24 hours 2 and again after 48 hours 2. Primaquine is contraindicated in pregnancy. In resistant cases, quinine salt 10 mg per kg into 7 days, artesunate 4 mg per kg in divided loading dose followed by 2 mg per kg into 6 days. Treatment of uncomplicated falciparum. First trimester, quinine salt 10 mg per kg TID into 7 days and in the second and third trimester, co-formulated tablet of artemether 20 mg plus lumefantrine 120 mg into 3 days. The next regimen will be sulfadoxine 25 mg into 3 days, artesunate 4 mg into 3 days and before these 2 drugs, pyrimethamine 1.25 mg per kg body weight on the first day. Drugs in severe and complicated malaria. Initial parenteral treatment for at least 48 hours. 20 mg on admission as IV infusion in 5D over 4 hours, followed by 10 mg over 4 hours TID. The infusion rate should not exceed 5 mg per kg per hour and if the patient has already received quinine, loading dose of 20 mg should not be given. Next drug will be artesunate 2.4 mg per kg IV or IM given on admission and then at 12 hours and then 24 hours once a day. Follow-up treatment after parenteral therapy, quinine tablet 20 mg followed by 10 mg TID into 1 week. Clindamycin 10 milligram per kg, 10 thali into 7 days, and of course oral artesunate. Pregnant women with severe malaria in any trimester can be treated with artemisinin derivatives, which in contrast to quinine do not aggravate the hypoglycemia, which has to be given much importance when you treat malaria. Supportive treatment, of course, blood transfusion in severe anemia, Paxils if hemoglobin 7 to 8 grams per day, 8 grams. Folic acid 10 milligram OD to prevent megaloblastic anemia. Fluid replacement, of course, with prompt monitoring to prevent pulmonary edema and aggressive and careful management of complications of malaria. Drugs contraindicated, of course, tetracycline, doxycycline, and primaquine. Management of labor. All measures to rapidly control the body temperature by cold sponging and antipyretics. Careful fluid management is very important. Induction of labor if situation demands. Fetal and maternal distress may need to shorten the second stage of labor, and LSCS if needed. Radical cure. For prevention of relapse of Vivax, chloroquine 300 milligram for 1 week until stoppage of lactation, and complete the therapeutic treatment after stoppage of lactation with chloroquine or primaquine for 14 days. Now the second topic is leptospirosis in pregnancy. This is typically a biphasic illness, and it has the two phases, phase 1 and phase 2. I think you can see it in the slide. Icteric leptospirosis is Wales syndrome, 5 to 10%. Fatality rate is 20 to 40%. Characterized by liver, kidney, and vascular dysfunction. Of course, anemia, thrombocytopenia, and prolonged prothrombin time. Now, fetal effects. Spontaneous abortion, intrauterine fetal death, especially of the second trimester. Congenital leptospirosis, especially if near term, even with mild infection. Signs of active leptospirosis, stillbirth, and neonatal jaundice. Diagnosis is mainly clinically supported by lab investigations. Direct detection methods, indirect serological methods, and here comes the modified Fain's criteria. Of course, you must be knowing this is the modified Fain's criteria. So according to this, presumptive diagnosis is made by a score of part A and part B, that is 26, and score of part A and part B and part C, 25. Possible but unconfirmed diagnosis made if score is between 20 and 25. And of course, the lab test, it takes 5 days before you come to a conclusion. And here the main thing is the MAT, which is the gold standard for serodiagnosis of leptospirosis, which is most effective and highly specific. Differential diagnosis of leptospirosis in pregnancy: influenza, dengue fever, meningitis, malaria, hepatitis, UTI, and other viral hemorrhagic diseases with hepatorenal failure following PIH, and septicemia of pregnancy. Now here the treatment for mild leptospirosis, OP treatment, rest and rehydration. Severe LSP, inpatient management with intensive care. Antibiotic management for mild leptospirosis: amoxicillin 500 milligram QID, ampicillin 500 to 750 milligram QID, azithromycin 500 milligram BD into a week. And modified to severe LSP, IV penicillin G 1.5 international units QID, and IV ampicillin or amoxicillin 1 gram QID for 7 days. In penicillin allergic patients, IV azithromycin 500 milligram QID, IV ceftriaxone or cefotaxime 1 gram QID into 7 days. Pre-exposure antibiotic prophylaxis is not routinely recommended due to danger in mother. Management in labor: vigilant fetal monitoring due to risk of placental ischemia and intrauterine fetal demise. As congenital infection is rare, leptospirosis in pregnancy is not an indication for termination of pregnancy. Multidisciplinary care with nephrologists, hepatologists, hematologists, and obstetric team becomes very needed. Close monitoring of fluid electrolyte balance is a must. Dialysis for renal failure if required. Blood transfusion for bleeding tendencies. Steroids and platelet transfusions for thrombocytopenia. And delivery need not necessarily be by cesarean. Vaginal delivery is preferable due to risk of coagulopathy, bleeding tendencies, and of course risk of anesthesia because of hepatic and renal dysfunction. Infants should be monitored for congenital leptospirosis and newborns to be treated by procaine penicillin until the tests are negative. Chronic sequelae of leptospirosis, long-term effects. Why I have put this slide is because the patients with leptospirosis in pregnancy must be monitored for 5 years after recovering because of the long-term sequelae. And you have to look for eye pain, uveitis, recurrent migraine, iridocyclitis, chronic fatigue, depression, obsessive-compulsive disorder, paresis, and encephalomyelitis. Now the third topic is dengue fever in pregnancy. Background. Actually, it is caused by any of the 4 closely related serotypes of flavivirus, RNA virus. Vector is A. aegypti transmitting to human. Most of the states in India are dengue endemic. Early detection and access to proper medical care reduces fatality from 20 to below 1%. Points to ponder. Of course, everyone knows the 3 variants: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Effect of dengue fever in pregnancy is unclear, although many cases have been reported. Clinical manifestations, treatment, and outcome in pregnancy is similar to those of non-pregnant women. It may mimic HELLP syndrome, pneumonia, pulmonary embolism, various obstetric causes of vaginal bleeding, and other infectious diseases. Adverse pregnancy outcomes like preterm labor, low birth weight, cesarean section are uncertain. Risk of vertical transmission is well established in the perinatal period. Severe bleeding may complicate delivery, and surgical procedures performed on pregnant mothers during the critical phase. And dengue fever does not warrant termination of pregnancy, and no sufficient data or probable embryopathy to mothers who had dengue fever in the first trimester is available. Now, the clinical presentation of dengue in pregnancy: 3 stages: acute febrile phase, critical phase, which is the phase of capillary leak, which is the very, very important phase, and the third one is the recovery phase. Now, acute febrile phase, you can just go through because I think there is not much time. The potential complication is dehydration, and in the critical phase, again, you can go through, and the potential complications are shock. In the recovery phase, the potential complication is volume overload. Warning signs of plasma leak has to be remembered. That is persistent vomiting and severe abdominal pain, increasing lethargy but mentally alert, large and tender liver, fall in WBC platelets and rise in PCV, cold and sinused extremities, rapid breathing, mottled skin, unstable BP or not recordable BP, pulse pressure less than 20 mmHg, tachycardia, weaker pulse, very feeble pulse, confused, restless, lethargic, and progressive signs of shock and death. Management of dengue fever in pregnancy is as Group B, and Group C. So Group A, no warning signs, and you can manage it in the OP. Group B, severe warning signs and IP management. Group C, any signs of severe plasma leak with shock, and again IP management. Group A management, do baseline CBC day 1 and day 2 of fever. If WBC count is normal or lower, suspect. Repeat CBC after 24 hours and compare further fall in platelets and rise in PCV. 10% rise is significant. Temperature charting, pulse, BP, pulse pressure every 4 hours. Urine output at least 4 to 6 hours. Group B management, monitor vitals, catheterize to know precise urine output, 0.5 ml per kg per hour. Intense fluid resuscitation, normal saline, bolus 5 to 10 ml per kg per hour for 2 hours, followed by 3 to 5 ml per kg per hour as a maintenance. Avoid induction of labor, planned surgery. Group C management, institutional management in the ICU setup, timely fluid management. Of course, the ceremonials before transferring the patient, and hand over all reports, fluid bolus details for reference for further treatment. Here the transfusion trigger is very important because it is low for dengue fever than in any other blood transfusion indication. So fresh blood transfusions if there is overt blood loss nearing 500 cc. Inevitable delivery during critical phase, bleeding should be anticipated and closely monitored. Blood and blood products should be cross-matched and saved. Trauma or injury should be kept to the minimum. Check for complete removal of the placenta after delivery. Platelet transfusion initiated during delivery. Fresh whole blood, fresh packed cells transfusions as soon as possible. Do not wait for blood loss to exceed 500 ml before replacement. Do not wait for the PCV to decrease to low levels. Oxytocin infusion commenced to contract the uterus after delivery to prevent PPH. Misoprostol for PPH prophylaxis. IM injections ought to be avoided. Post-delivery, newborn should be closely monitored because at or near term or at delivery, severe fetal and neonatal dengue illness and death may occur, so baby to be evaluated for congenital dengue. Discharge from hospital. When do you discharge? If afebrile for 24 hours without antipyretics, if the appetite is normal, hematocrit at baseline value and rising trends of WBC and platelets. So with this, wishing you a happy Doctor's Day and prescribing you a day full of smiles, I can conclude my talk. And until I meet you again, I wish you happy moments, healthy life, and safety practice also. Thank you once again. Thank you.